Hello, dear colleagues. Uh, I'm Ahmed Ossama, Sweedan, Associate Professor of Oral and Maxillofacial Surgery, Faculty of Dentistry, Alexandria University from Egypt. I hope you are all good and enjoying your day. Today we are going to discuss with each other the dental implants and the TMJ disorders and how they affect each other in a positive way and in a negative ways. So that we could finally see if they are really beneficial to do implants for patients with TMJ disorder, or it's harmful to do implants with pain with TMJ disorders, or see if it's a cause of the problem or a relief for the problem. In fact, most of you are working on dental implants already, and saw some complications of dental implants, uh, and so some beneficials from dental implants. However, today we are concerned with TMJ. TMJ is a very large subject, and it needs to be discussed for sessions and not in a webinar. But we are going to make it brief to understand the cause and effect of the problem of the TMJ, how it could be used as a benefit for dental implants, and how we use an implant as a benefit for TMJ. We are hoping to understand the problem or the cause of the TMJ disorders at first, then we will understand the effect of the implants on TMJ and how to avoid its negativity and make it a positive, that we can create a treatment for TMJ from using dental implants, which is a really good subject for us for treating patients and finding another ways to treat TMJ. You know, treating TMJ disorders is very, not, there is no such only one way we can treat TMJ disorder, but we are trying multiple ways. Most of them nowadays, we are using conservative methods, such using splints, which is very effective and not harmful for the patient. Dental implants could be used in the same way and could be not harmful for the patient and beneficial for TMJ disorder as well. So dental implants is considered one of the factors that is a part of complete dentistry. What's meant by complete dentistry? We use periodontal knowledge, we use prosthetic knowledge, we use surgical knowledge, all of them to rehabilitate the patient, to make it a good function and a good life for the patient. So it is not a specific department. We are all multidisciplinary team to act in that implants to make it beneficial for the patient. In our part as surgeons, we are concerned with TMJ problems. So that's what makes us talking about it now. The masticatory apparatus is a very complicated, but it's simple to understand. But in action and how it works, it's very complicated, as it involves three main subjects, which is occlusion and muscles of mastication and the areas surrounding it, such as cheek and lips, and the temporomandibular joint as well. So how they affect each other and how they act in harmony with each other, and how this harmony, if this missed, will be harmful for the TMJ and the patient start to complain from it. To understand the TMJ problem, we must understand what is meant by protective muscle splinting. Protective muscle splinting is a really mechanism that is present in all our joints, not just TMJ. It's present in every joint in our body. But the TMJ has a specific character that is not present in other joints. We will discuss it briefly to understand the problem, where it comes from and where to treat it and how to treat it. The protective muscle splinter is present in all our joints. It is joining the tendons and muscles and the joint, which aim to protect the joint from overloading or underloading. So there is proprioceptive fibers that is present in the tendons of the muscles that feel the pressure that acting from heavy weight or low weight and send these messages to the central nervous system. The central nervous system send the reaction to the muscle. So it adjusts the action of the muscle according to the feeling of the proprioceptive receptors. That makes us move freely and without harming our joints by heavy weights or small weights or overacting or underacting. That's what is meant by protective muscle splinting. It acts on all joints. But in the TMJ, it is different. Why it is different? Because these proprioceptive fibers are not present only on tendons of the muscles. No, they are present around the teeth itself. It is present in what we call a periodontal ligament of the tooth. The periodontal ligament of the teeth is considered the tendons around the teeth. It is swimming and attaching to the periodontal ligament that feel every minute pressure that over the tooth. Such pressure could be harmful to the tooth and may break it if not controlled by the brain. So these symbols and these signs that the proprioceptors collect, send it to the brain, and the brain, without us feeling of it, in the subconscious level, send to the lateral pterygoid muscles, and specifically lateral pterygoid muscle and the other muscles of mastication, to direct the jaw to avoid this harmful high points such as high restoration or crown, but not implant, and we see it now. So if I made a high restoration to the patient will close once and twice and third. Then he starts, if we remain the high point, he will come the next phase and feeling good. Well, how it is feeling good? It is still high, because the protective muscle splint started to protect the tooth from this high point by tilting the jaw itself and considering changing the occlusion of the patient itself. So such intercuspation, that's what's called centric occlusion. And we'll talk about our centric occlusion and centric relation itself. In the presence of occlusal interference, as we said, the lateral pterygoid muscle can never be relieved of this function. Otherwise, the malaligned teeth will be stressed and will be break. The mechanism that forces this prolonged contraction onto the lateral pterygoid muscle is sensitive protective reflexes system that guard the teeth and their supporting structure against excessive stress. Such protective muscle splinting saves the tooth from stress, not the TMJ. It's not considering the harm of the TMJ, it's considering just the harm that or the tooth itself. The protective or the proprioceptive symptoms is designed like a glove of periodontal receptors capable of evaluating the direction and the intensity of stress on the teeth. And this proprioceptive nerve index is scattered through the periodontal ligament, and as we said before, and sensitive to even minute pressure on individual teeth. These proprioceptive receptors are designed to program the lateral pterygoid muscle specifically to position the jaw so that the elevator muscles can close directly into the maximum occlusal contact. And here is a really important point, that the maximum occlusal contact is what we call centric occlusion. And the centric occlusion is relation between the tooth and the tooth, the upper teeth and the lower teeth. It's maximum occlusal contact. It's not like centric relation, which is relation between the bone of the mandible and the base of the skull. That's why they may differ from each other. Actually, we all have different centric occlusion than centric relation. And if they are not in harmony with each other, the problems of TMJ will come to you. What's the problem of the TMJ? First of all, the lateral pterygoid muscle start to be in a spasm. It can't relax. If it relaxes, the jaw will, the teeth will crash each other. So the lateral pterygoid muscle is always in contraction. And not only the lateral pterygoid muscles, the other masticatory muscles will be always in contraction. That's what makes pain, muscular pain, that could be in the temporalis, and the patient suffer from headache. Other problem is that the lateral pterygoid muscle also attached to the disc, which can be anteriorly displaced, which makes the anterior disc displacement of the jaw. The anterior disc displacement of the jaw could be in the first, it would be reducible, which make clicking sounds on the TMJ. Then it will be non-reducible, which make the limitation of movement of the TMJ itself and loss of click. which is more painful to the patient because it's pressure on the bilaminar zone. In the premises of occlusal interference, the right pterygoid muscle, as we said, can never be relieved of this function. Otherwise, the malaligned teeth will be stressed. This picture shows us the superior head, which attaches to the condyle and to the disc. And this superior head of lateral pterygoid muscle is the one that makes the anterior disc displacement, as we said before. So this unique relationship between the lateral pterygoid muscles and the proprioceptive periodontal receptors is so definite that even override the normal tendency of muscle to rest when it has become fatigued. The muscles cannot relax, and the proprioceptive present contraction as long as the occlusal interference is present. So the occlusal interference will be not felt, but the muscles start to go on into a spasm. Okay, spasm means pain later on. The pattern of deviation is reinforced every time the contact is made and is retained in the brain's memory. That's what's called muscle engrams, so that the muscular closure into the deviated jaw relationship becomes automatic. Okay, that's a muscle program, and the muscle engram that will be present for the patient as long as the occlusion is kept as it is, not in harmony with the centric relation. Okay. One important fact is that the proprioceptive memories, however, is that fades rapidly in continual reinforcement if continual reinforcement of the pattern ceases. That means that if we remove the high points and we aligned correctly the teeth, this protective muscle splint start to fade, and this pain start to fade. Such thing, we can see it in the patient after multiple extraction of teeth and make it an edentulous patient. The edentulous patient mostly have no problem with the TMJ. Elimination of the interfering contacts permits almost immediate return to normal muscle function. The fatigue of a spasm that occur after long hyperactivity of the muscles lead to pain in the muscles. And the sensory nerve index in the muscles are highly sensitive to lactic acid buildup and also to ischemia. This present ischemia will be a stimulation of pain of the muscle itself. These pictures shows us the difference, and which could be considered, as we see, as a minute difference between the centric relation and the centric occlusion. But also the minute difference, that means the lateral pterygoid and the other muscles of mastication keep spasming and keep function and cannot rest, because it's every time it closes into muscular intercuspation, which is centric occlusion, it harms the TMJ more. Such a way could lead to anterior disc displacement, and this anterior disc displacement because of the lateral pterygoid pulling the disc anteriorly. So every time the patient is opening, we'll click on the anteriorly displaced disc. How to treat such conditions? It's simply by removing these high points. How we could remove it? Either we make a selective grinding of these high points to make an harmony, or what we call the long centric, with the patient, that makes the centric relation and centric occlusion almost the same or in harmony with each other, or making occlusal splints, which is considered as a conservative treatment of the TMJ. So what we are thinking here is the problem of the TMJ is not an anatomical problem, it's functional problem, okay? So occlusal splints is made to protect the TMJ from this protective muscle splint. The occlusal splints, they can prevent the existing occlusion from controlling the jaw-to-jaw relationship at maximum intercuspation by providing a smooth surface, which gives a chance of correcting the position of the condyle disc assemblies and relief of any spasm in the masticatory muscle. The problem of the TMJ will appear as a signs of muscle pain, which can be a headache, anterior disc displacement, we can hear sounds of clicking in the TMJ, otalgia, pain in the TMJ and the anterior to the ear itself, which can be mediated to the ear itself and making otalgia, headache, and even blurring of vision due to presence of musculatory muscles at the base of the skull, which can be spasmed around other vital structures like the optic nerve and lead to blurring of vision. So such signs and symptoms can be very annoying for the patient and make him seek for other specialties, not the oral and maxillofacial surgery. These types of the splints can be soft occlusal splints or hard. I'm, in my opinion, the best splint made for the TMJ is the permissive type of splint that designed to unlock the occlusion and remove deviating tooth implants from contact. Directive splint is very good, but if you can record specifically the centric relation, because the directive splint is designed to position the mandible in a specific relation to the maxilla, which is the centric relation, not the centric occlusion. And this directive splint, we can, then in this lecture, we can make the full mouth rehabilitation using implants, using the bridge on the implant as a directive splint. We can make it, if it's in centric relationship, we can see it as a directive splint. So the centric occlusion, as we said, the maximum intercalation, and could be different from the centric relation, as we see the difference between these pictures. But the patient, it's not as an orthodontic view, he's class 1, he is good in occlusion, there is no problem, but he is complaining of TMJ. Why? Because there is no harmony between centric relation and centric occlusion. That's what makes the TMJ problem. So this patient is, as we can see it, a class 3 when he closes his mouth, but after placing a splint, a permissive type splint, we can see that he retains to be an edge to edge. So this inclination of teeth and this malaligned teeth makes him to deviate the mandible more anteriorly, which makes the centric occlusion not in harmony with the centric relation, and this makes the problem of TMJ. So such is using a permissive type splint with a smooth surface on the upper teeth makes the patient able to close his mouth in a centric relation while using this splint. This splint is used to relieve the muscles from spasm, so the headache will be lost, and to relieve the anterior disc displacement from being pulled by the lateral pterygoid muscle to allow it to return back to its position. So this briefly was the description of the TMJ disorder, how it comes, and how we can treat it in conservative ways. What the effect of the dental implants on the TMJ? And what's the difference between the dental implant or the tooth? The answer is the difference, the main difference between the implant and the tooth is the loss of periodontal ligament. And as we said before, the periodontal ligament is a glove of proprioceptive fibers. So this patient or any implant is placed in the alveolar bone has no perioproceptive fibers present around it. So the mechanism of the protective muscle splitting will be absent. Okay, there is no protective muscle splinting is present around the implants. So they are not protected. When we say protective muscle splinting, this protection is considered to the teeth, natural teeth, but the implants are not protected. They have no periodontal ligament, and that's what makes up. But the patient may feel that the implant may be high after a while, or this sensation will come in a different way, not the proprioceptive fibers. It's called osteoperception. And we can see it when we over torque the abutment while we are inserting it in the implants. He will start to feeling some pressure. This some pressure after overloading with the torque to make the patient feel it. But this takes another way to the brain, longer way. It's not direct pathway to the brain. It goes through the skin, as we see here, then the masseteric muscles, then the TMJ, then the brain is in. So the reaction is totally different. The patient or the brain will not consider it as a tooth. No, he will consider it as a foreign body. So he will not accept it and he will reject it. Okay. So that's why this picture shows us a lot. this canine, the natural tooth canine, is endodontically treated with a post in it. It's supposed to be fragile. It's supposed to be brittle than the implant. But we see the neighboring implant was fractured. Why was fractured? Because it is not protected. There is no protective muscle splinting for it. So the prosthesis over it was high, and after pressuring and harmful forces on the implant itself, it becomes fractured. But the lateral tooth is protected because of the prodental ligament allowed it makes the jaw deviates and there is no high points affecting it. So the natural tooth is protected, but the implant is not protected. That's why we must consider occlusion. I am oral Maxillofacial surgeon. I am not the prosthetic part, but we should all who is interested in implants must be interested in prosthesis. The prosthesis is a very important part of the dental implants. The occlusion is very, as we are saying now, all my speech is about occlusion. So the occlusion is very crucial. We can't avoid it, or we can't make it less important. It is very important for the longevity of the implant. Not only the bone loss we are seeing, no, that it may fracture the crown, fracture the implant itself, fracture the abutment. It could be very devastating for the patient that after some years he comes to you with a fractured implant. So we are in webinar for MGM. Fractures of the implant is not a problem for the implant itself. It mainly becomes from a harmful occlusion and occlusion that didn't consider the protective muscle splint that is not here with the implant to protect the teeth from it. So abutment fracture or fracture of the implant of the crown must be considered as a problem of occlusion at first of all. Also, abutment loosening. Even if the system of the implant is affording you a cold welding between the abutment and the implant, also abutment loosening is a problem. Why? Because it is occlusion and the teeth. Normally, there is minute movement in the teeth. For the class 1 and class 2, as we know for all natural teeth, but the implant is not moving. When we adjust the occlusion, we put the articulating paper and we see it, okay, it's fine with the other, and the patient is not complaining, especially if they are two implants opposing for each other. But by the compression of mastication, the patient didn't feel the high point, but it is existing every time the teeth is collapsed with each other. The periodontal ligament acts as a cushion for it, but there is no cushion in the dental implant. So that the abutment loosening is also because of the high points that is present in the prosthetic part of the implant. Also, our talk here was on single implants, but if multiple implants is present, we are here talking about different types of how to avoid over occlusion and over force over the dental implants. There is anterior guidance, there is posterior guidance, there is lateral excursions, all these just a second.
ممكن.
Okay. So So here we are talking about multiple implants present, but in this picture shows us natural teeth present with the implants parts. We should put and consider, as we said before, that the occlusion, there is centric occlusion. Here we will adjust it according to the occlusion of other natural teeth, such as centric occlusion. We are not dealing with centric relation yet. We adjusted on centric occlusion, but we put in consideration the guidance of the teeth with that there is no load on only one direction or only one tooth on the prosthesis. No, we try to multiple teeth to more disturb the forces over the all implants we have placed. So in these cases, there is mixed dentition, natural and implants. We use that centric occlusion as a reference. But when we are dealing with full mouth rehabilitation, we must consider the centric relation. Centric relation as we are using for complete denture prosthesis, removable denture. Here we can say it's like a car that have multiple sensors and cameras for it, which presents a protective muscle splinting. And then we removed all these sensors, and the car become an old car. We should use and stick back to the complete denture prosthesis occlusion, which was the centric relation. So here the centric relation must be equal to the centric occlusion for this patient, such as the long centric concept. The long centric concept is used and described by Dawson. Dawson is a real good book for us to review the occlusion and the relation of the occlusion to the TMJ, which is very important to us and to the dental implant field. The concept of long centric, it gives us a space to the centric relation can be have a way to help itself to avoid over force on the teeth. The long centric is mainly for the anterior teeth that we grind slightly as the cingulum to make it a wider, to make the teeth, the anterior teeth not breaking each other and not labially pushing each other more. So that's the other important factor is the curve of speed. The curve of speed should be established in our procedures for the patient of full mouth rehabilitation. Also, the bilateral balanced occlusion. All these concepts, we remembered it from the complete denture procedures. We must make it also for the patient of the full mouth rehabilitation. These patients also, we should not use the full anatomic structures of the crowns because it makes more inclines and makes it harder for us to reach the centric relation for the patient. So we can use the implants as a treatment for TMJ disorder from what we talked before. How? Because if the patient is already has a malocclusion and the centric occlusion is not equal to the centric relation that led to TMJ problems, so we can use these implants to make a whole mouth rehabilitation and the new occlusion of the teeth. And this rehabilitated teeth, we make it on the centric relation. Such case, we will reach to the cause of the problem and we will deal with it. So dental implants can open as another way of the treatment to treat the TMJ using full mouth rehabilitation, which can be used for us and more stable results. So the TMJ disorders can be treated using full mouth rehabilitation using dental implants by reaching for the centric relation. So the centric relation is the key to help the implant to succeed more and decrease the resorption of bone and decrease the fracture of the implant, a fracture of the prosthesis around it. Last thing we will talk about bruxism. The definite cause of bruxism is not yet known. There are some children with 1.5, 2 years with still new occlusion, new teeth. They make bruxism on their teeth. So the bruxism is not well known, but it could be an effect of TMJ disorder and could lead to a TMJ disorder. So what we deal with bruxism is mainly protection of the dental implant. Dental implant has no periodontal ligament around it that act as a cushion or protect the teeth from or compressed during occlusion. So we may make a perfect occlusion, and by the paper points, we see it as a occlusal point, we see it as perfect. But when the patient bruxism on it, we will have high points on the implants. After a while, this implant may fracture, or the crown fracture, or the bone resorb around it. So we must use a night guard to save and protect these implants for every patient that suffer from bruxism. That's for all, I think, and I don't want to make it so long for you. So if everyone has a question, you are allowed to ask. Thank you all for your listening and attended of this presentation, and hope you like it. Thank you.